difference at the ground level. Our department at Center for Community Medicine also runs a CR Southeast Asia region NCD delivery network with medical colleges from almost all the countries of this region, which focuses on patient-centered NCD care. Therefore, I can easily see why how we two of us can work closely with each other and strengthen each other's network. This is already a packed session, and we have some eminent speakers who probably know more about it than me. Therefore, it is best that we give the floor to them and not spend too much time on our talk. My only request to the speakers is you have been given 7 minutes, so please try to stick to the time so that we don't encroach on other people's time. Thank you. Now it's my pleasure to invite the one and only Professor Srinath Reddy, President Public Health Foundation of India, and I don't think he needs any introduction to this group, so I'm going to save time by not speaking further about it. Dr. Reddy, please.
Thank you very much. It's a great pleasure to be part of this consultation, which is dedicating itself to mobilizing the power and conviction of people living with NCDs into a force for change in not only the planning process for delivery of health services, but also ensuring that these services are efficiently and equitably delivered across the country. While having gone through the COVID-19 pandemic, I believe NCDs were masked in terms of the attention they got from the health system. But clearly, NCDs were very much the major background against which the COVID-19 pandemic played out. If you really look at the comorbidities which landed people with severe illness after they were infected, or landed them in intensive care, or led to unfortunate fatality, NCDs were the dominant comorbidities. While age also played a role, we recognize that at older ages, NCDs are quite common, but even at relatively younger ages, it is the presence of NCDs as comorbidities unrecognized or undertreated, which resulted in severe illness. We also recognize that NCDs were a collateral damage, with all the preoccupation of the health system in addressing all of its energies towards the recognition and care of persons with the COVID infection. The limited resources of the health system were greatly swamped by the demands of the COVID pandemic. And many people who needed care for their NCDs did not get attention from the health system. And during periods of restricted movement, they not only did not get the medical attention they sought from the care providers, but also possibly access to medicines also became a challenge. But there is yet another element. It also revealed that NCDs have been major blind spots of our health system so far. When it was prioritized by the policymakers that persons with NCDs must be prioritized for vaccination, initially those in the 45 to 60-year age group, but later on, even currently, when we are talking about the protection doses being given to those above 60 with comorbidities, it became very clear that many of the people with NCDs were probably unaware that they had NCDs. The health system had not recognized them to have NCDs, or they could not have documentation of their NCDs. And particularly in poorer sections of the population, rural areas, smaller towns, these areas of missed cases and missed opportunities of the health system to detect them would have actually rendered it very difficult for recognizing all people with NCDs, even if the system aimed to protect them with timely vaccination. So that again brought out how our health system has failed to recognize and provide due care to people with NCDs prior to the pandemic. Therefore, it's absolutely important that we address our efforts, and there, people living with NCDs can become a very important force for motivating change and mobilizing people resources and government commitment for bringing about that change. The civil society overall has to really direct the further transformation of the health system so that we now start rebounding in terms of the attention being paid to NCDs and build that system which actually pays due care even in the non-pandemic period. We do recognize that civil society, particularly people living with NCDs, can bring about a great deal of change by drawing attention to the magnitude of the problem and also raise a considerable amount of empathetic response from the other members of the public. They can raise awareness in the community. Now, apart from drawing attention of the policymakers, they can also build capacity for implementation. Not only because of the experience, they can actually build capacity among the frontline health workers by collaborating with them. And also, now that the 15th Finance Commission has brought about a considerable degree of change in the way in which primary healthcare will be rendered through the medium of local bodies, the panchayats and the urban local bodies, allocating funds directly to them and making them substantially responsible for primary care. Sensitizing them, the local bodies, to the problem of NCDs and the nature of prioritized services that must be provided. These, again, we can work with the local bodies, both the panchayats and the municipal corporations, to build that capacity. Building capacity among citizen groups is going to be important, and also building capacity among people living with NCDs for self-care, self-monitoring. All of these are going to be absolutely important. Finally, I would like to say that it's absolutely important that we start building coalitions and join forces. Particularly, we recognize that we have to take advantage of the broader platform offered by universal health coverage, because that is where efficient, equitable, and empathetic health system must draw its inspiration from. And there, I believe there's a great opportunity to position NCD-related services very prominently on the platform of universal health coverage, but also extending it to the broader platform of sustainable development goals. Ultimately, what we need is people-partnered public health, and people living with NCDs can actually ensure that this particular movement draws its energy and momentum from their own experience, their own vision, and their own articulation of the need for change and the channels of change. Thank you very much.
Thank you, Dr. Reddy. It's my pleasure now to invite Dr. Bulbul Sood, who is a senior strategic advisor to Jibago and again must be well-known figure to many of you in this panel. She will talk on effective community mobilization and involvement of people living with tuberculosis. What worked in our experience with tuberculosis? So Dr. Bulbul Sood, please go ahead. And I now request Dr. Seema Bali to introduce the next two speakers after Dr. Bulbul Sood.
Thank you very much. First, I would like to thank the organizers for giving me this opportunity to share the work. In fact, I was asked to talk about HIV, but I told them that currently Jibago is working in the area of, we are not doing anything in India on HIV, and that's why I said I like to talk about the community engagement under the National Tuberculosis Eradication Program that we have started very recently. Can you just move? Next slide, please. So I'll try to share with us our experience of working with TB patients under our NISHTA program. This is a USAID supported program where NISHTA is providing core support in the area of effective and responsive technical assistance for strengthening the comprehensive primary health care. Also, developing an ecosystem for co-designing and testing innovative solutions, and developing strategic partnership between the public and private sector. And we are doing this to ensure effective delivery of accessible, affordable, and quality care for all in the area of comprehensive primary health care, which covers maternal, newborn, child health, family planning, and tuberculosis, school health program, and healthy hygiene behavior. In the TB area, the key areas that NISHTA team has been working is in engaging the family members for the care of TB and the drug-resistant TB patient. And as you heard previous speakers say, that it is very important not only to involve the patients, but also the family members. And there is global evidence that we can do a lot by involving the family members also. We also looked at integrating TB and again, the drug resistance TB services in the Ayushman Bharat Health and Wellness Centers, capacity building of the primary healthcare teams for delivering these services, and also developing vulnerable scorecard for differential TB care, because as you know, there are more need to immediately address those who are high risk. Empowering TB champions, especially, and the PRIs and the community members as an advocate for TB, which you are all talking about advocacy, very important at the community level. And TA for also integrating the TB and maternal health services. Next, please. So why engage with the community? And I don't have to share why, because all of you are aware that it is very critical that we engage the community. And as somebody says, nothing for us without us is the key that we have to all ensure. And as per the National Strategy Plan of TB elimination 2017-25, it definitely talked about placing community not as passive recipients of care, but as an active, motivated stakeholders. And the inputs from TB affected communities enhances the decision-making processes on the issues that impact the well-being of all. Engaging with the community, as you all know, not only makes the treatment available to everyone, but also facilitates reaching the unreached, which is very important, especially as we know that we miss out on a lot of important cases, ensuring better access to services, increasing the social acceptance of those who are affected by tuberculosis, breaking down the barriers, and especially there is, silence and myths around people living with TB, improvement in overall quality of care, and generating increased social, legal, and political commitment. Next, please. So our approach in the NISHTA program was to drive solutions through technology, leveraging the institutional mechanism, engaging the families and the communities, and empowering the TB patients, which would lead to quality of TB care services for all. Next, please. So the key interventions where JPIGO worked for community engagement under the National TB Elimination Program one was engaging with the TB champions. And as you know, there is a Government of India is working with the TB champion, and we are supporting its rapid scale up across the country by building the capacity of these champions for providing TB care. The second area we are working is on participatory care model, which is the demonstration of the effective engagement of the families and frontline workers, and ensuring that the TB services are provided to all. Then, of course, engaging with the Jan Arogya Samiti And this is a platform which is created for awareness and engaging communities for the TB services. And last but not least, the innovations for community engagement. And here we are working by utilizing telemedicine, telecounseling platform, and IVS-driven training platform for access to TB services and information. Next, please. So some of our achievement in engaging in the last 1 year, and this has been during the time of COVID pandemic when it was difficult to reach out, but a lot of this was done through use of digital technology. So we have been working with the CTD since the very beginning of this program, and we have developed the operational guidelines for TB services at the health and wellness centers. We've been also working with the state government for the capacity building of the community health officers on TB. So besides developing a learning resource packages for training of the CHOs, we have been also providing technical assistance to the 14 states across the country for training the CHOs. And so far we have almost trained 9,000 CHOs in these 14 states. We're also collaborating framework for management of TB patients. And this again has been the work which we have done with the CTD and maternal health division. And as you know, that many times during pregnancy, TB is not addressed. And we are using the platform of Village Health and Nutrition Day for screening and counseling pregnant women for tuberculosis. The vulnerability scorecard has been developed, and this is again used for screening for identifying the high-risk TB patients among the patients who come to the health and wellness centers. Engagement of the TB champions has been one of the very important activity of this program. And again, in partnership with the CTD, we have sensitized TB survivors to become the TB champions. And as you heard earlier also, that those who have suffered or are the best one to motivate others to go for a treatment and complete their treatment. And as of now, today, we have trained more than 1,000 TB champions. And as the training is going on, and they are doing excellent work in the communities. And last is implementing family care giving model for TB. So this is what we have just started in Madhya Pradesh in 2 districts. And the plan is that we are going to be with an aim to train, to reach out to almost about 1,500 TB and multi-drug resistant TB patients through the community health officers. And again, we are envisaging that by doing all these activities, by involving the communities, we would be able to reach out to and ensure that we reach the goal of TB elimination. Thank you very much.
Thank you, Dr. Sood, for such an insightful session. Most of the things were quite new to me. I have noted that all down, and it's really important for us to share this with others too. May I please request Dr. Atreyi Ganguly, National Professional Officer, Mental Health and Abuse, WHO, to take us through the WHO framework on meaningful engagement of people living with NCDs and mental health conditions as significant to India. Over to you, Dr. Atreyi Ganguly.
Good afternoon, everybody. Am I audible?
Yes, ma'am. Yes, ma'am.
Okay, thank you. So at the outset, I must congratulate the organizers for coming up with such an important event or consultation. Definitely, it is the need of the hour. And many thanks for giving WHO an opportunity to be a part of this event. So without further, I would like to, if my presentation can be shared so that I can start my presentation. Right. So yes. So the outline of my presentation, today I'll be talking about the WHO framework on meaningful engagement of people living with NCDs and mental health conditions and its significance for India. So next, please. The outline will be primarily, we'll see how COVID has caused disruption of services for people living with NCDs and mental health, and how this took to the development of the framework. In fact, it is the development of the framework is, the process is ongoing. So we'll see how it transpired into this thought process of having a framework for meaningful engagement, and also what are the opportunities for engagement with people living with NCDs in India. Next, please. So going through quickly, you can see how COVID has disrupted services. It is known to all. This is a part of the country profile which WHO brings up from time to time. This was released in early Feb, and it shows 50% disruption for NCDs. Next slide, please. And more than 1/3 countries have shown that there is disruption for mental health, neurological, and substance use disorder services. So next slide. So this brings us to what the situation is vis-a-vis what what are the WHO perspective for addressing NCDs and mental health conditions. As we know, the WHO in 1978 during the Alma-Ata Declaration had emphasized the importance of the community engagement in primary healthcare. Community definitely is inclusive of people who are living with NCDs. So definitely they are a very important key stakeholder, and they need to be empowered and included in all decision making. Secondly, for NCDs, WHO has advocates for continuum of care from prevention to palliation. And even palliation, I would stress, because it gives the person an opportunity of life of dignity, life of care, life of not being at the mercy of others. So this is, of course, a lot of right-based for people who are living with NCDs. In terms of prevention, a lot of focus is given on the prevention and control of risk factors, both for NCDs and mental health, and we know what are the risk factors. And there is a process called the health promotion, which WHO advocates very strongly, which is primarily the process of enabling people to have control over themselves and improve their health so that they can take decisions which are good for their health, like being away from the risk factors of NCD, being the unhealthy diet, lack of physical activity, tobacco, alcohol, and substance abuse. Even the internet addiction is nowadays an important thing. And this led to a very important slogan: nothing for us without us. So next slide, please. So we've seen how NCDs have been, there has been disruption of services for NCDs during the COVID times, and the COVID times had brought in new challenges because they're competing priorities in terms of human resource, in terms of the logistics. The resources are limited, especially in countries like India, and so there was a competing priority. So it led to the health systems to take very judicious decisions of how to balance the two. While there is need for continuing with the NCD services, including mental health, there's also need to allocate resources for COVID-19. So under these challenging circumstances, it led to the thought process that we need to have the inclusion of the people with NCDs, living with NCDs and mental health, to actually share what is the basic need. So this led to, the thought process that we need to have a WHO framework. So this process has just started. As you know, WHO is divided into 6 regions. We just had the Southeast Asia Regional Consultation this month, will be followed by other regions. And so the viewpoints of different countries will be taken, and this will give us the understanding of the regional perspective, the barriers of implementation, how people can be engaged. Certain areas like mental health, there's a lot of stigma, how people with mental health conditions can be included and mainstream, whereas, and at the same time, optimizing the limited resources. So the next slide, please. So in India, also a similar thought process is very applicable. In India, we have a lot of opportunities, and there are available platforms like the national program for different NCDs and mental health, palliative care, tobacco control, drug addiction. So there are array of programs. These are actually points of entry for people who are living with the NCDs. How we can rope them in, how we can get them into this process of decision making, of policy making, because the inputs given by these people are actually the first-hand inputs, which will help better planning. We also have the health and wellness centers, which are coming up in a big way, and they also contribute to the primary healthcare delivery system. There are a lot of legal policies and frameworks, and I must say, I must congratulate the Government of India for bringing up such progressive acts like the Mental Health Care Act, the COTPA Act, and also the Mental Health Policy. These are right-based. We, like under the Mental Health Care Act, the person can, if there is coercive admission, then the person can actually appeal. Also under COTPA, it gives the person the right to a healthy living. So these are the legal frameworks which exist, and it helps a lot for people who are living with these NCD conditions. And of course, we have the array of NGOs, CBOs, etc., who are actually contributing to the community. And today we have many representatives from such NGOs together with us, and I must salute them. They are doing a commendable job. Also, other ministries are there, like we have the Social Justice and Empowerment Ministry, which gives rights, which protects the rights of many of the marginalized communities, like people with disabilities, both physical and intellectual, people, older people, definitely, who are, of course, a marginalized group by themselves, and also, people who are into addictions, etc. And other relevant ministries do exist who give financial support to the ministries, like, to the people living with NCDs, etc., the grants, the Prime Minister's Relief Fund, etc. So these can be in a big way leveraged on to get into, to have a better planning system. Next, please. Yeah, so I would just take a minute more to share the key messages. Yes, NCD is one of the major cause of morbidity and mortality in India, and it has to take the central stage. It had been, by the NCDs were coming up with the advent of COVID. Definitely, there is competing priorities, but we have to, judiciously balance the two. Because of the disruption of services, there has caused a lot of inequalities. We really need to see how we can salvage the situation. It's very important to have the inclusiveness in our planning. for ensuring the rights of the people and for people with NCDs. And these are very important, as Dr. Reddy said, that we have to attain the goals of SDGs. It is very important. And last but not the least, the participation of all key stakeholders is crucial, and all means even the people living with NCDs and mental health conditions. So with these words, thanks once again for giving WHO an opportunity, and I wish this event the very best. Thank you.
Thank you, Dr. Ganguly. It was really very nice to hear what all you said, and the data that you shared was, I was not surprised. I, being a teacher, at this platform, I will share that nowadays we are bringing back children to school, and we really face a lot of issues, mental health issues in our children. And we lost one girl due to mental health issue. She, died by suicide 2 months back. And so we were really shaken. So the rule in our school, the thumb rule for all the teachers is be kind. And for the students is reach out, reach out to us, reach out for help, talk to us. So that's what we, instead of bridging the gap in academics, it's now, bringing their mental health and speaking to them, talking to them about their general wellness. So that was very well taken, Dr. Ganguly. Thank you so much. May I now request Dr. Balasubramania, Advisor, Community Processes, Comprehensive Primary Healthcare, National Health Systems, Resource Center, and Government of India, on India's experience and vision meaningfully involving people living with NCDs in the community process. Over to you, Dr. Balasubramania.
On karo?
Yes.
Connection is unstable. Sorry.
Yeah, we can hear you, Dr. Balasubramania.
Dr. Subramanian, are you having any connectivity issues?
No, I'm trying to get this one. You have to unshare your this one because.
Sir, we have your slides already.
Okay.
Do you want to share your slides?
Yeah, you can go ahead.
Okay.
So we have not received your slides, so we will just disable our screen sharing and we will just share. Yeah. So you may share your slides.
Yeah, I'll share my screen.
Thank you, sir.
So कोई फिफ्थ नेशनल कॉन्फ्रेंस थी ना, वो आपने ज्वाइन किया है क्या?
Sir, are you having an issue with your screen share?
Some issue in this one. I just reboot and then re-log in. I'm not able to get the.
Okay.
Should we initiate discussion on the earlier presentations in the meanwhile, while Dr. Subramania is able to present? We can also get presentation of Dr. Subramania and try to then screen it from our system.
Yeah, sure, that would be fine. I think I'll request the chairs to, we're a little behind time, but I'd request the chairs to initiate an open discussion till the time we figure out the issue with Dr. Balasubramania.
Thank you, Radhika. So the session is open for any questions. Anybody has a question, you can type it in the chat or you can speak out in the forum itself. There does not seem to be too many questions. It need not necessarily be a question, it could also be a comment. You're welcome.
Dr. Balasubramania is back. We may ask him if, sir, if you're able to share, or if you would like to email them to us, we may share the same.
Is my screen visible now?
Yes, we can
Yes,
see
sir.
it.
Yes, sir.
Yeah.
Yeah, you may want to switch to
Yeah.
presentation mode, but we can see your screen. Thank you.
Yeah. Good evening, everybody. My apologies for this technical problem and for the delay that it has caused. Thank you very much for the opportunity to be amongst you. I'm extremely sorry because we have been running from one meeting to another and we have got the budget meetings of all the states going on. And hence, it has been a difficult time to actually move into it. So, however, I would like to spend some time talking to you with respect to what you have shared in terms of the experience or a vision, more importantly, meaningfully engaging people with NCDs, which it's quite close to my heart in that context. I would say I'm reminded of the JIPA principle that HIV/AIDS actually looked at, the greater involvement of people affected. And I think we have come a long way from HIV, and probably there are a lot of lessons that we are learning from the HIV pandemic, which actually helped us rework on the way chronic diseases are managed. And in that context, many of the points that would be emerging in due course of time would be influenced by our own experiences and the way things have emerged following the active engagement of people who are affected. I'm just reminded about the situation that I had personally faced when I was a medical student and a medical intern in my alma mater, the Mysore Medical College. My professor was actually a diabetic, and after every rounds, clinical rounds, we used to go to, he used to get us a cup of coffee. And when we were going to the coffee shop, invariably, because we used to go at different times after the rounds, invariably the person who's going to serve used to always change. And every time a new person comes, my professor used to actually call him to the side and whisper something to his ears. And I was wondering, and I did not have the courage as a medical intern to go and say, well, what are you whispering into that server's ears? Then after about a couple of days like this, then I asked one of my postgraduate students, my senior there, and I asked him saying that, what does professor actually tell every time he comes to this coffee shop? Then he related, saying that professor is a diabetic, so he wants a sugarless coffee. And so he is actually telling that in this one. So those were the days when a professor of medicine was hesitant to reveal that that person was a diabetic. And today, I think things have changed quite a bit in terms of we broadly proclaiming, saying that we are a sugar factory ourselves, and hence we don't require additional sugar. So we want sugarless sips of coffee or tea. So things have changed. In that context, engaging people with NCDs in the community processes makes a lot of meaning at this context. Well, if I go through the way things have emerged in the last, I would say last 3 years specifically, 2018 we started, and the discussions that we always look at with respect to how are we universalizing care. And you know that the Great Triangle was what was served for quite some time in this country. And slowly the big component of the NCD care, which was actually not available to the common people closer to their homes, was made available with the launch of the Ayushman Bharat, which was the forerunner for the universal health coverage. This envisages three important elements. The first and the foremost thing that you look at is nearly 2/3 of the problems we should be able to solve at the primary healthcare level. That means primary healthcare is a whole of society approach. It is not about a care provider to a care recipient. So in that context, everybody, the patient, the family, the society at large, okay, and of course the care provider and the overall health system are all integral part of the entire approach to this. And all these things have to be available closer to their home. This is the second important thing. And this should emerge of not only looking at care after disease, but preventive, promotive, curative, rehabilitative, and palliative care. This is the narrative that has propelled the Ayushman Bharat Health and Wellness Centers. And today, actually, on a mission mode, the government is actually operationalizing Ayushman Bharat Health and Wellness Centers across the country. I'll be sharing the numbers, which necessarily means going beyond the gray triangle. We're including the white triangle, and we're clearly looking at a referral gatekeeping, which ensures only those people who really need a specialist consultation at the secondary care level, moving up to the green trapezoid and further up to the tertiary care pink triangle. So in which case, I would say the primary healthcare not only ensures comprehensive care, looking at all dimensions of care, but also acts like a clear gatekeeper and a referral to ensure continuum of care upward. And the other integral part of this program is the downward referral, which has to be looked at. So this narrative has built the entire Ayushman Bharat Health and Wellness Center program, and this is one which gets augmented. And the levels of service delivery has been very clearly defined at the individual level, the community level, the sub-health center level, the PHC level, and the secondary care level. And if you look at the entire spectrum, there is also a lot of horizontal integration. For example, I'll tell you, the work with the local women and child development department, the education department, the youth affairs and sports department, all those horizontal integration that we talk about is clearly envisaged not only in the policy, but which is also translated into budgetary commitments in the rollout of the Ayushman Bharat Health and Wellness Center program. Now, going beyond only the caregivers, there is also a clear focus on Eat Right movement. And so the Eat Right toolkit is actually made available up to the ASHA level. Then there are Eat Right Magic Box, which tests all the food for adulteration are being made available at the primary health center, health and wellness center level. And to propel the actual movement of NCD care, etc., a Fit India movement was launched not only for encouraging people to be active by themselves. A Fit Health Worker campaign was also added last October 2nd to show that the healthcare providers should first get tested and demonstrate that people can come forward. So in that context, the health workers campaign, so the screening happened amongst the healthcare providers level. So if I look at the entire trajectory of how the rollout has been happening, so as of today, 90,385 health and wellness centers are physically present. Well, I would like to qualify that health and wellness centers are expected to deliver 12 comprehensive package of services, virtually dealing with both illness and wellness, as well as looking at womb-to-tomb care. So in that context, whether it's an emergency care or a pregnancy care or a elderly care or a palliative care is integral part of the spectrum of the health and wellness center framework. Now, what is the issue there? Why am I saying physically possible? Look at the entire spectrum of health promotion activities. We have a health and wellness ambassador program. There is an annual health day, which is actually, there are health calendar days. There are nearly 42 days, out of which many of this one, whether it's the Cancer Awareness Day, whether it is actually the World Cancer Day or World Heart Day or World Elderly Day, everything is integral part of the annual calendar of events. And these calendar of events are clearly brought in to engage the community in the process of seeking care, delivering care, as well as monitoring care. So this is the whole framework in which the entire design has happened. So reiterating the fact that the design has got already established. The design is got budgetary commitments. The design is now getting translated into this one in an evolutionary manner at the grassroots level. Now, if I look at the overall things, as I told you, the community-based assessment checklist, which the ASHAs go after a population enumeration, creating a family folder, the checklist today, cumulatively, nearly 28 crore such checklists are already available in the health and wellness centers across the country on a cumulative number. If I look at the total screenings that have happened for 5 of the important elements, the hypertension, diabetes, oral cancer, breast cancer, and cervical cancer, there are nearly 46 crores, 88 lakhs, which have been actually looked at. Whereas the treatment people, number of people new and old who are currently on treatment as of yesterday was 42 lakhs, 9,723. Well, I'm only talking about the design components. I'm actually looking at whatever has been accessed. The SMS feature, if I look at, this is also being unveiled as late as December 13th to 2021, where a timely screening failure, they get an SMS because all those people who the phone numbers are got in the family health folder, they get a timely screening and rescreening SMS from the health and wellness portal. They also get a reminder for checkup after a 1 year, this one, and also for the continued treatment follow-up visit. If they are referred to a higher center, they get a reminder to complete referral visit. These provisions are already made within the technology environment of it. Going further, to ensure that there is uniqueness in every ID, there is already the nearly about 17 crores Ayushman Bharat health IDs, the digital mission health IDs, which is the ABA account. You know, Ayushman Bharat health accounts have been already opened up. And this is also integrated into the NCD app, which critically means that the person who goes for an enrollment at a health and wellness center can get a health account created at the health and wellness center, which is just maximally half an hour away from his home. This possibility is definitely there within the system today. So now what is the issue? I think there is a lot of focus on the supply side, lot of pressure on the supply side. What is critically important is the demand side propulsion, both in terms of not only awareness, but an energy into actually utilizing the services. So this is where the whole condition came. So for that, there are certain mechanisms that are actually coming up, this one, and it is already, there are certain problems. One is the clear guidance, clearly asking the at the health promotion, whether it's participation in annual health days or regular yoga sessions for which there is a budgetary allocation, nearly 2,500 rupees can be actually spent on a monthly basis by every health and wellness center for a minimum of 10 sessions at the local level. And anybody who is a yoga trainer from the local community can actually get into the health and wellness center, deliver this session and earn that money. So it is made open, universal. Then the school health and wellness ambassador program has been rolled out, and there are 24 sessions covering 11 topics which are focused on higher education and the secondary education students. And for each health school, there is one male teacher and one female teacher who are health and wellness ambassadors, who would actually start teaching this on a Tuesday, which is the health and wellness day in the school. And this component has got this one. So the design issues I'm trying to clarify to you, saying that this is available and this is already being this one. And many of these elements that I'm telling you up to the state level, both in terms of the budgetary allocation as well as the training component, apart from the guidance issues, guidance which has been released, is already commissioned. Utilization of services and encouraging peers is a part of the screening agenda, where people have to mobilize within themselves. Then, of course, there is utilization of teleconsultation. Probably, you know, yesterday's in the pre-budget session, it has already, this one, nearly about 2.5 crore teleconsultations have happened at the health and wellness centers level itself. Additionally, the ASHAs and the ANMs are supported for patient support group meetings at the sub-health center level and incentivized for that too. Beyond that, Ashas for the expanded package of services are also eligible for an incentive of nearly 1,000 rupees per month. So these provisions are actually made so that the propulsion is already there. Apart from that, in order to ensure that the health and wellness centers become community owned and community monitored, a new multi-stakeholder committee called Jana Arogya Samiti is being created. The guidance has already been issued. States have already budgeted. States already have training programs rolled out, and states are in the process of composing the Jana Arogya Samiti in each of the health and wellness centers, whether it's at the sub-center level or at the PHC level. And in addition, there is an increase in, I would say, untied grant from 20,000 to 50,000 during this period. In this, one clear thing that you have to look at, apart from the service providers, the elected representatives and the civil society members, which include several self-help groups and other people who are there, with more than 50% of the composition being women, service recipients, that means there is specifically people who are actually affected. It could be a TB patient, it could be a diabetic patient, it could be a hypertensive patient. They have an opportunity to become a member at the sub-health center level Jana Arogya Samiti, which is an oversight committee on the on the health and wellness center, whose responsibility is to meet on a monthly basis, look at the entire work framework. The community health officer or the mid-level healthcare provider is the member secretary of it, and the Gram Panchayat chair is actually the chair of this. And these issues, right from the upkeep to the opening to the utilization of the untied grant to ensuring availability of drugs and diagnostics as per the guidance, where the sub-health center is supposed to have 14 types of tests and 105 different drugs in the essential drug list, which includes all the BP and diabetic drugs that we are talking about. And at the primary healthcare center level, which is 63 tests and 172 drugs, there is an additional 15 Finance Commission grant which has been provided to this one, where it covers all the diagnostics for the next 5 years. So there is no state which can ever complain that they don't have money for diagnostics. Okay. So that's the amount that is there. In fact, they are finding ways to actually not only fulfill this, but they would have left out money to actually add on to the diagnostics at the district level too. So that is the amount that they all
Bala, if I may,
so considering all these things, so that means there is an opportunity for the affected people to be participating in the Jana Arogya Samiti, participating in the village health and sanitation and nutrition committees, which is a village level
Dr.
committee.
Bala, you have to kindly wrap up quickly.
And also being tasked. We have actually started off in a mechanism where, whether it's a CHO task guidance being drawn, or NPCDCS Ayush guidelines being brought in, or a wellness training module being drafted, the task force already is asking affected members to be part of the task force. So these are opportunities that are existing in the design. This is what I would like to reiterate. So going forward, while I can definitely say the architectural design is in alignment, the implementation processes are in different stages of evolution, depending on different states. For example, if I look at Odisha, Odisha has gone quite a bit on many of these elements. Okay, this one. So there are the states which have done extremely well on technology issues. Some have done extremely well on community participation issues. Some have done extremely well in terms of integration issues. Okay, but these are in the evolution. As on date, the government guidance says by 15th August 2022, all the Ayushman Bharat Health and Wellness Centers operationalized by March this year should be able to provide all the necessary services. This is where, so that means you have 6 months time for the states to actually ensure action on the ground. So considering these points over there, I would say this is a golden opportunity for the entire nation and the citizenry of the nation to actually proactively seek participation, get engaged into the process, hold processes accountable on one side, and more important, utilize the services at their level. Because if you don't utilize, there is no way things will change. It is like I have worked in the tribal belt for 30+ years. So I can tell you honestly, whatever, even in a small kirana shop, if people don't ask, that fellow will not going to sell that material. Okay. If people start using it, there is a demand created, the pressure builds on the system, and naturally they will start indenting for those elements and ensure availability of it. So I would say it is as much a government governance issues as much as the citizens' responsibility issues. So there is an opportunity, there is a framework for which things can be taken forward. And here is this one, that as civil society organizations, as citizenry of the country, we need to take this framework onto the hand, which is a clearly, there is a budgetary commitment also apart from the guidance notes to ensure operationalization of at least the 110,000 centers that are going to be operationalized by March 2022. So with this, I would stop for discussions forward. Thank you very much.
Thank you, Dr. Bala, for that excellent presentation on what government is doing to improve community participation and patient participation in management of diseases. As you know, patient engagement is not an NCD specific issue, it is a generic health issue. Since we are already behind time and I don't see any questions in the chat, we are going to end this session with some concluding remarks from the chairs. So may I ask Seema to give her concluding remarks?
Thank you. A big thank you to all the speakers for sharing such information with us, which frankly, I was not aware of most of the things. And as I shared with the speakers as and when they were speaking, but for Dr. Bala, for Dr. Subramania, I would like to say that health and wellness programs in schools are well taken. We all, being from a school community, I can assure you that if we are taking it in spirit, and the students are also doing it, and teachers are also, executing it to the T. So it's very, it's empowering, and it is good to see that each one of us are on the same page, and we are working towards a big change that we need to see. A lot needs to be done, and a lot of action needs to be taken. But I'm sure with all of us together, we'll achieve that. With this note, thank you so much, everyone, and over to you, Dr. Anand.
Thank you, Seema. So I think almost all the panelists were in agreement of the need for involvement of patients. Dr. Reddy pointed out that the lack of awareness and literacy among patients could be a good barrier, which also resonates with what Dr. Balasubramanian was saying about the need for demand generation. Because that's going to be critical in driving this way forward. However, we do also realize that there has to be a lot of effort from the health system point of view. We did have good examples from Nishta from Dr. Bulbul, and how they are using replicable models are there to involve patients into tuberculosis, which can easily be replicated for NCDs. So it's good to see that things have been done, as also the initiatives which Dr. Balasubramanian presented on especially looking at JAS and the Jan Arogya Samitis and others, which are mechanisms which are already available and which can be exploited to strengthen the patient engagement in the management of chronic NCDs. And obviously the use of technology was highlighted both by Dr. Bala as well as by Dr. Bulbul. So we know technology cuts both ways. It has both, it's a dual weapon. Too much use of technology is also sort of a disempowering for patients. So we need to be careful on that. Finally, I think Atrey presented on the WHO framework, which is still a process, which has been consultation happening. And I'm sure this consultation and subsequent engagement will definitely contribute to that process, and we'll have a much more, in a typical WHO listing, we have a good framework for us to work on. So with that, I thank all the panelists for their excellent presentations and for the meaningful discussion. And I hand it back over to the organizers. Thank you for inviting me.
Thank you so much, sir. I will now request our co-chairs for the third session, Dr. Swati Bhave, the Executive Director of the Association of Adolescent and Child Care in India, and Dr. Kavita Singh, Senior Research Scientist, Public Health Foundation of India and the Center for Chronic Disease Control, to please take the lead of this session. And I will ask all speakers to please be cognizant of time. Thank you.
Thank you, Shikha. Good evening and welcome to all to this third session. May I request Dr. Bave to present the opening remarks, please?
And I thank the HIA for giving this opportunity to be co-chair with Kavita for this session on meaningful involvement, evidence and action from the ground. I apologize for the mirror image which has come in the background. I'll have to check my settings why this happened. So we know that evidence and action from the ground is something which is very, very important. And as a person who has been living with NCD, I have an autoimmune disorder for the last 40 years, and being a doctor myself, and then being a patient when I'm not well, I know how difficult it is to be a patient unless you have an empathic doctor who understands you. And sometimes it has not happened even with me being a medical doctor. And hence, the evidence and action from the ground is extremely important. And our first session speaker will be a desk review mapping exercise of published examples of community engagement undertaken by HIA by Shikha. We also will hear from civil society representatives from Punjab, Dr. Rakesh Gupta, and from Maharashtra, Dr. Vinod Shah, on their access to quality healthcare and telemedicine services during COVID-19. And I attended one of the regional consultation by Janseva, Dr. Vinod Shah, which was extremely enlightening. And the pandemic has made it very clear that in order to strengthen healthcare delivery and access, people with lived experiences are important stakeholders. And all of us as pediatricians and adolescent medicine, we have been doing teleconsultations over the last 2 years. I myself have done more than 100 teleconsultations. And it really makes us understand that if a person does not have access to teleconsultation during this COVID period, what problems they have undergone and how much the healthcare has suffered. And I look forward to these three presentations. And I request Kavita to introduce the speakers. To keep to time, I have not made my comments very lengthy. Kavita, please take over.
Thank you very much, Dr. Bave. Also, since we are already running behind the schedule, I would skip my opening remarks, and it's with great pleasure I would like to invite the first speaker, Dr. Shikha Basin, who is Senior Program Manager at HIA, and she will be presenting the evidence from the desk review, the mapping exercise done by her. Over to you, Shikha.
Thank you so much, Dr. Singh, and I'm going to rush through this. So this mapping exercise was conducted on past examples of meaningful involvement, which are within the NCD and health landscape of India and even beyond other development sectors as well. And this is being supported by the NCD Alliances Advocacy Institute, NCDs and UHC Accelerator Program grants. So we are thankful for them. And this was done with an evaluation of all public literature, that was scientific literature that was available. Next slide, please. So starting with what exactly is community involvement? So as per WHO, it is the idea of partnership and shared responsibility within health services rather than just the notion of using the community to reduce the burden on health services. And beyond its use to enhance effective implementation of health programs, it also has a positive impact on social capital, which enhances community empowerment and leads to improved health statuses and reduced health inequities. Community engagement does cover a wide range of processes from mobilization to empowerment. But while mobilization is viewed as an external push to the community, community empowerment expands the opportunity to participate in, negotiate in, influence, control, and to hold accountable institutions that affect the well-being of the community. Next slide, please. So from the literature that I found, these are the different thematic areas where I was able to find literature. It is obviously not just restricted to this, but the majority was seen around reproductive maternal newborn health. There was great amount of literature on HIV/AIDS, on infectious diseases that included polio, malaria, and Kala Azar, NCDs, kidney disease, diabetes, cardiovascular risk factors. The most robust examples of community engagement were from HIV and polio, and beyond the space of just health issues were linkages to schemes such as health insurance schemes and other schemes, community involvement and engagement in city development programs, and water and sanitation and education as well. Next slide, please. So these are the mechanisms of involvement that were seen. So I will go at these one by one. So for committees, the examples seen were formation of health committees, hospital management committees. We know about the village health, sanitation and nutrition committees, and village-based reproductive and child health committees. For example, there was the Indian Local Initiatives Program, which was for RMNCH. So they had communities, members who were actively involved in the planning, implementation, and resource mobilization all around family planning, maternal child health, and reproductive health program. And they also had local management committees that oversaw the service delivery in villages and urban slums that were guided by a locally designed work plan. In Maharashtra, similarly, a program that was done to target anemia used women's self-help groups, adolescent girls groups, farmers clubs, and 20 village coordination committees for the same. Another example is under the NHM, the Rogi Kalyan Samiti, or the Hospital Management Committee, which is a community mobilization and participation initiative. So it facilitates community members to participate and ensure proper management and functioning of public healthcare facilities. And it has a wide variety of members from the local Panchayati Raj, NGOs, locally elected representatives, leading members of societies, and those from the government sector. The last example I would give is the Village Health, Sanitation and Nutrition Committee, which have been formed to take collective action on issues related to health and the social determinants at a village level. Again, these committees have a variety of members in them, and they're meant to create awareness about nutritional issues and carry out surveys on nutritional status and nutritional deficiencies. The biggest thing with this committee is it acts as a grievance addressal forum on health and nutrition issues. Next, I would move on to community-based action groups. So this also includes people with lived experiences, and the biggest example here is what is being done for AIDS. They have Ashodhya Samiti groups, which have male, female, and transgender sex workers, whose job is to promote condom use, HIV testing and counseling, link HIV positive sex workers to ART centers for their treatment, and they also volunteer in hospitals to ensure that fellow sex workers receive adequate services and aren't discriminated against. They expanded their use during the pandemic to also adapt their HIV outreach program to form alternative community-led system of distributing ART medicine, and also using WhatsApp to distribute information on accessing government social benefits as well. For polio within Uttar Pradesh and Bihar, there was the use of the Social Mobilization Network, or the SMNet. So the intervention mobilizes communities by the way of a multi-pronged approach using religious leaders, community influencers, interpersonal communication, counseling, mother meetings, and also has rallies that target resistance to polio immunization. It has community mobilized coordinators who are in charge of about 500 households who engage with families through interpersonal communication towards sensitizing them to get their children to get the OPV. They also use children as mobilizers, forming groups called Bulawa Tolis to carry out positive vaccination messages throughout the communities, and also track smaller children, motivate their mothers, and even bring children to booths for polio drops. Another community action group was also done within an NCD project done at Ballabgarh, where risk assessment camps in the community and industrial sites were also used. It also put forth guidelines for healthy promoting schools and workplaces, and schools and workplaces were also sensitized to further promote these guidelines. Next, moving on to community health workers. The Mitanin program was one of the first ones that started in Chhattisgarh, which then fed into the ASHA program. So I'll focus on the ASHA program, which is a key component under the National Rural Health Mission, who is a female community health worker selected by the community. The ASHA is meant to cover a variety of health issues, right from RMNCH to NCDs, but we do know that the focus is more RMNCH heavy. Apart from that, they also anchor the community-based platforms created under the mission, such as the Village Health, Sanitation and Nutrition Committees and the Mahila Arogya Samitis in urban areas. Other examples of community health workers is a SIM card study, which was done for high vascular risk individuals. And within that, they used participations who were managed by the community health workers through the use of an app on a monthly basis, which focused on medication and lifestyle modifications. Within awareness generation, which a lot of the interventions focus on, one example is a CUP study, which was done in Chennai to promote physical activity through community empowerment and with an attempt at primary prevention of NCDs. The focus was heavily on education regarding the benefits of counseling and mass awareness programs using public lectures, video clippings, and distribution of educational materials. Similarly, the Kerala Diabetes Prevention Program, the KDPP, was a group-based peer support lifestyle intervention which aimed at reducing the risk of type 2 diabetes. Similarly, the intervention included a group-based peer support program which focused heavily on awareness generation. Within community-based monitoring, which is another component, one intervention which was done was the Community Action for Maternal Health by the NGO Sahaj in Gujarat. So it involved awareness generation of maternal health benefits, supporting community monitoring of services, and facilitating dialogues with health providers and other stakeholders. Community monitoring included home visits to women who were 8 months pregnant, as well as postpartum using a Healthy Mother tool. Similar examples are through Sathi, a state nodal NGO. There was a community-based monitoring done in Maharashtra, which was actually included in its state PIP. So within this was organized at the village, the primary healthcare, block, district, and state levels. The PHC monitoring committee collected the results from village report cards, monitored services within the PHCs, and passed this information up to the block level. These led to a successful community-based monitoring program, including filling of report cards, which we will get to later. Within women's groups especially, there have been trials done for reproductive and maternal health, like the 8-youth clustered trials, which was done in Odisha and Jharkhand, which included monthly meetings of women's groups to discuss problems related to pregnancy, childbirth, etc. These discussions were led by local facilitators trained in participatory communication methods who had received basic training to discuss health problems during pregnancy and childbirth. Another example which extends beyond the health sector is how SEVA, the Self-Employed Women's Association, utilized their community-based centers, the Seva Shakti Kendra, to empower women workers to attain entitlements. So this basically provides hand-holding support to scheme beneficiaries through raising awareness, support ensuring correct documentation for registering and facilitating use. And this is for women of the informal sector who make up one of the most vulnerable sectors. Their focus is on schemes for health, nutrition, and childcare, as well as the PMJ. Moving on to scorecards, one example is how Sahaj, the NGO, tried to assess the demand and the supply side of primary healthcare centers. So for the same, they had a color-coded system to denote what was the service delivery, whether it was poor, average, or good. Similarly, there was a project done in Andhra Pradesh under the Rural Poverty Reduction Program, where community scorecards were used to assess performance of 2 primary health centers. And these were informed by the community. So they had a quantitative and a qualitative element, which helped to aggregate indicators. And then the qualitative element also fed into justification of the choices made. And on the supply side, a service provider self-evaluation generated indicators as well, such as doctor availability, staff behavior, PHC services, etc. Similarly, in Maharashtra, under the Maharashtra Rural Water Supply Program, there was an assessment done of the performance of Gram Panchayats across village Panchayat services, water, sanitation, and health. And it was seen that community scorecard processes led to feelings of user satisfaction and empowerment as well. Moving on to participatory action research. Some examples, and I would also want to highlight at this point that we are thankful to HIA members who also provided inputs of projects that they were working on. So a STOP chronic kidney disease study, which was done in Andhra Pradesh to understand and mitigate the effects of chronic kidney disease, had a very strong community-based element in the designing of the study, which involved detailed interactions with frontline health workers and the PHC medical officer, as well as community dialogues with members to voice concerns over what are the major health problems. So this was a very rich community element as a pre-design phase of the school, and also involved the formation of a committee with the A&M, ASHA, Anganwadi worker, etc. A 6-month community-based diabetes program, prevention and management program was also done in rural Gujarat, which also followed a community-based participatory research method, which was done to tailor interventions by engaging trained community health workers as agents of change to provide lifestyle education, serve as community advocates, and collect data from the participants. And to ensure that there was true community participation, the entire rural community was inducted into this partnership, where the village elders, research team, and elected community health workers discussed and obtained a clear understanding of the purpose of the study, its usefulness to their community, and the anticipated outcomes. This study was able to pinpoint that diabetes was one of the major problems. Other examples.
Sorry to interrupt. Please, can you quickly wrap up?
Yes, yes, I'm almost done. Other examples include the use of public hearings as well as digital platforms. Next slide, please. So the key observations that came from this is that community participation is mostly limited to awareness generation, using community health workers as an interface, and health screening for a majority of interventions. However, there are a few examples like HIV and polio, which have successfully embedded community engagement and allowed people with lived experience in the larger community to take accountability for their health. We also want to highlight that there are interventions which are focused on meaningful engagement and participatory research methods, as we've seen. And till date, there are minimal community participation for NCDs, which focus mostly again on screening and risk mitigation. Last slide, please. So going forth, what we would recommend would be the way programs like HIV and polio have action plans and guidelines that delineate how to bring in CSOs and community engagement. The same is needed for NCDs as well. Another thing is that a lot of studies are smaller, they are not of very large scale, but they have shown successes. So likewise, subnational level successes should not be discounted, and they should be scaled up or replicated if possible. A bottom-up approach is necessary, which emphasizes the participation of the local community in developing initiatives so that they can select their own goals and the means of achieving them. And lastly, from COVID, what we can learn is the use of risk communication and community engagement. Sorry, this is the end of my slide, but I'm just flowing into the next session, which is what I will be doing. So we then complemented our desk review with primary findings, wherein we documented subnational level work on community involvement and also gleaned barriers for accessing health services, especially for people living with NCDs during COVID-19. For the same, next slide please, we conducted stakeholder dialogues to understand the current landscape of community-based monitoring and planning action. And we also conducted state-level web consultations to provide a platform to people living with NCDs and CSO partners to engage with policymakers on discussions and deliberations related to community action for health. So thank you. I will stop here.
Thank you very much, Dr. Shikha, for that insightful presentation. May I now invite the next speaker, Dr. Rakesh Gupta, who is currently President and Director of Public Health at CIFA, that is Strategic Institute for Public Health Education and Research. He is also former Director of Health Services at Punjab. Over to you, Dr. Gupta.
So thank you, Dr. Swati and Dr. Kavita. So I think we are already running late, so I'll just take 5 minutes. And Shika, can you share the presentation? So I'll be sharing my personal experience as actually till recently I was in government with Government of Punjab, and now I'm working with the CIFA. But I think so. I have experience of both the as a government officer and as an NGO, as a CSO. So actually the challenges, so next slide, please. So we have actually at the national level and at the state level also. So we had almost similar challenges and opportunities in harnessing the telemedicine services during COVID-19 in the state of Punjab as well. So the challenges were because we had never faced such a pandemic like COVID-19. So, and it was very sudden also. So as we all know, the challenges were that since our teams were focusing on the treatment of the COVID-19, so the NCD patients, the people living with NCDs, they had to suffer a lot. And because most of the OPDs, the general OPDs were closed, the surgery for the those cardiovascular diseases and for the cancer patients, so they were not happening. So they had to face a lot of challenges. They could not approach the doctors directly. So these telehealth services, they really made a lot of difference in accessing the health services. So experience of accessing healthcare and self-management of NCDs, it has been great. As a NGO also, as CSO, we learned a lot in COVID-19 that how to use these digital platforms. So earlier we used to do physical workshops, and then we shifted to those webinars. And in Punjab, luckily we had a good network of health wellness centers. There are 2,000 plus health wellness centers. Though most of the staff was busy with the COVID-19 management, but they could provide succor to the patients approaching them. And we also, the Cypher also helped them in providing internet connectivity, and we provided them almost 300 dongles so that they could connect to the doctors who were sitting in the hub. And so with the provision of the Wi-Fi dongles, they could, the number of calls, they increased from 10-15 in a day to almost 100 in a day. So I think that was good use of technology. And they could also get the e-prescription from the doctors. So it really helped. And another thing Government of Punjab did was, there are 3 warehouses in Punjab. So from one of the warehouses, so they provided medicines for the NCDs, for the hypertension, for the diabetes, so directly to the health wellness centers. So that helped a lot. And there was almost no, I mean, you can't say that there was shortage of medicines during the COVID period. So there was the patients, they could easily access the doctors through the hub and through the CHOs actually, basically, because they approach the community health officers, and community health officers, they approach the doctors through that telemedicine services, and so providing succor to the patients who were approaching them. So, and the people living with the NCDs, they also devised their own ways to tackle with the issues, because they had problem in accessing the diagnostic services and accessing the doctors directly. So Cypher, with the help of the Red Cross, they could provide a tele helpline service that was available actually pan-India, not only limited to Punjab. It was pan-India, and about 35 experts were there, including dietitians and the yoga experts, and even a physiotherapist was there. So the people who were home isolated, they could approach us, and they could be guided. And we stopped short of prescribing any steroids. And if required, if the situation was that bad and they were suffering for NCDs, they were referred to the specialist to whom they could approach. So I may just enlist the recommendations that the capacity building at subnational levels for the people living with NCDs is required. The state level multi-sectoral working group can be constituted, comprising of people living with NCDs civil society organizations, doctors, academia, and the government definitely. So develop state level guidelines for meaningful involvement of the people living with NCDs, CSOs for NCD prevention and control. And as I said, the technology that made a real difference, and technology, it is an integral part of current and future health system strengthening, and it has to be tapped appropriately. And we need to provide easier, more accessible telemedicine options, as well as train and provide support to the people living with NCDs for self-management and digital literacy. As you must have heard, Dr. Ms. Seema, she has done a lot of work, as a champion. So CSOs may be involved towards strengthening of the telemedicine services in the state, as well as capacity building of CHOs, community engagement involving civil society and people most affected and at risk is fundamental to effective health responses. So the community and the people actually who are involved with the NCDs, who are suffering from NCDs or living with the NCD patients, they need to be involved in every part. So at the planning level, monitoring and surveillance, and the capacity building has to be done. So we need to adopt best bias or the good practices from other development sectors, like we heard from Dr. Sood, how they are tackling the cases suffering from tuberculosis during the pandemic. So to inform community mobilization and NCDs. So we need to adopt the good practices of others. So thanks a lot for the patient hearing. So I think Shikha, you can call the
Thank you very much, Dr. Gupta, for sharing your rich experience from Punjab state. Sorry, yeah. So we'll move on to the next speaker now. And may I invite Dr. Vinod Shah, who is chairman at Jan Seva Foundation, to share his experience from Maharashtra around accessing digital health services during the COVID pandemic. Over to you, Dr. Shah.
Yeah. Thank you. At the outset, I thank organizers, especially Hindi India Alliance, Radhika ji and Dr. Monica Arora. We had a lot of opportunity to work with on these non-communicable diseases in Maharashtra, and it's a great pleasure to present our findings here. I am Dr. Vinod Shah, and I am suffering from. I am now 75 years old and suffering from this diabetes and asthma for last 45 years. So I have experienced all this, and I am a senior most physician here in Pune Hospital. So I am daily looking after all these patients of non-communicable diseases. And I myself had COVID-19 positive disease, and I have treated more than hundreds of such COVID-19 positive patients. So I will start my presentation accessing digital healthcare services during COVID-19 by people living with non-communicable diseases. So, Maharashtra has been one of the states in India to be hit the hardest by the COVID-19 pandemic, with the highest number of cases of any state in India till date. So all of you know that. Till February 2022, Maharashtra has had over 78 lakhs confirmed cases of COVID-19 and over 1.4 lakhs deaths. The state has fully vaccinated over 50% of the population, and with over 70% of the population having been administered the first dose. Higher rates of mortality in most affected states like Maharashtra can probably be explained by the level of comorbidities existing in their population. Maharashtra is vulnerable to non-communicable diseases because of its geographic, political, economic reasons and rapid urbanization. In Maharashtra, National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, Strokes has focused on strengthening infrastructure, human resources and health promotion activities, as well as diagnosis, treatment and referral activities. Even we had our NCD centers at primary health centers. As of recent, over 32 lakh patients have been screened by for non-communicable diseases only in Pune and Satara district. So this Healthy India Alliance and Jansewa Foundation held a web consultation on 28th of January. The purpose was to provide a platform to people living non-communicable diseases and civil society organizations or NGOs to engage with policymakers on discussions and deliberations related to community action for health. The web consultations were centered around access to quality healthcare services and treatment during COVID-19 and the digital divide in accessing telemedicine services during the pandemic. The web consultation was attended by this community social organizations or NGOs, government representatives, and medical fraternity and people with lived experiences of non-communicable diseases. So it was very effective, I must tell you that. So next slide. So based on the stakeholders' interactions and web consultations, discussions were centered around these 4 themes. Firstly, challenges and opportunities in harnessing telemedicine services during the COVID-19 in the state of Maharashtra. So telemedicine provided opportunity for counseling. Challenges included a lack of privacy, confidentiality for counseling. Accessing telemedicine services was easier for households in urban areas compared to rural and for those who had younger people in the households who are more technologically savvy and can use internet-based apps such as WhatsApp. These people living with non-communicable diseases were comfortable using telemedicine. Telemedicine was used by civil society organizations to help link patients to specialists, and digital platforms were used for awareness discussion. The experiences of assessing healthcare and self-management of non-communicable diseases during COVID-19. Senior citizens, those with comorbidities, had restricted access to healthcare services. During lockdown, everybody knows that. Now, self-management presented some challenges, especially while carrying out routine daily activities and stepping out. During COVID, people living with non-communicable diseases faced shortages of supply of medicines. They were extra vulnerable during the pandemic. The lessons learned from the virtual and in-person healthcare delivery for non-communicable diseases during COVID-19. Loss of face-to-face sessions with doctors led to attrition of some patients. So patients were not happy. While most participants were comfortable conducting counseling via tele consultations, it helped if they were older patients where a rapport was already built. Routine services had gotten impacted, seeing a reduction of patients in OPD and IPD by 40 and 20% respectively between 2019 and 2020. 50% reduction was seen in endocrinological cases, but that is not only endocrinological, all types. Even we had to postpone all our planned surgeries during that period. So patient had to suffer a lot, including bypass surgeries. So senior doctors felt limited in being able to see patients personally due to their own comorbidities. So with this short findings, I will just say some recommendations. So capacity building at subnational level for for persons living with non-communicable diseases is required. State level multi-sectoral working group and committee can be constituted comprising of these people living with non-communicable diseases, then these civil society organizations, doctors, and the government also, planning and resource allocation has to be strengthened for prevention and control of non-communicable diseases in the country. Provide easier and more accessible telemedicine options, as well as train and provide support to these people living with non-communicable diseases for self-management and digital literacy. Awareness generation and screening for non-communicable disease, followed by lifestyle interventions. Technology is an integral part of current and future health system. So we have learned a lot from this COVID-19 disease for strengthening and needs to be tapped into appropriately. Develop state level guidelines for meaningful involvement of people living with non-communicable diseases and this community, the civil society organization. Adopt best buys and goods practices from other development sectors to inform community mobilization for non-communicable diseases. So thank you very much for giving me this unique opportunity here to present our findings.
Thank you very much, Dr. Shah, for keeping up to the time and for sharing your rich experience from Maharashtra state. I'm sure this would be very informative and will inform the document that Radhika and her team are developing to build the agenda around meaningful involvement of people living with NCDs in India. I thank all the three speakers in this session, and as Radhika has already mentioned in the chat box, we have a very exciting and interesting session, panel discussion that's coming up on catalyzing an action agenda for meaningful involvement of people living with NCDs in India. So over to you, Radhika. And
yeah, I just wanted to conclude. Thank you, all the speakers. Shikha's map was very, very enlightening. And Dr. Vinod Shah and Dr. Rakesh Gupta, it was wonderful, the experience which you shared and the recommendation which you have made will be very, very useful to all of us. Thank you so much.
Thank you very much. Yeah, over to you, Shikha.
Yeah, thank you so much, Dr. Bhave and Dr. Singh, Dr. Gupta, Dr. Shah. And now I would want to invite our moderators for the panel discussion, Dr. Ratna Devi, the CEO and co-founder of Dakshma Health and Education and the chair of the International Alliance of Patient Organizations, as well as Mr. R. Narendra, the executive director of the Alzheimer's and Related Disorders Society of India, to please lead this session. Thank you so much.
Thank you, Shikha. Thank you for giving me the opportunity, along with my co-chair Narendra, to lead this session and have a wonderful panel discussion with 4 stellar panelists. We started this morning with a consultation on non-communicable diseases and universal healthcare, 2 very heavy topics. And then we put into that a meaningful engagement of people living with NCDs. And that in itself is an extremely heavy and very large topic. And we had some very interesting discussions since morning, discussing around all of these topics. But today's panel discussion is how do we mix and match all of these and come up with some actionable agenda points that Healthy India Alliance can take forward? And how can we then set up something which is a multi-stakeholder initiative? So everybody adds their bit to it, and we come up with some points that can actually be taken up as coming from the evidence of the meaningful engagement, coming from the information that people with lived experience give us. We should not forget that the lived experience is a journey. A person who is diagnosed, or even a person who is not diagnosed but is having signs and symptoms, lives through a journey until they come to the end of the disease, or they are cured of the disease if it is curable. And every touch point in this patient's journey has a different aspect that needs to be addressed. And each of these touch points can be addressed by different stakeholders. So how do we get all these stakeholders onto one platform? Since we are already behind time, without much ado, I would like to call on stage our first panelist to give his remarks on the topic, which is Framework for Meaningful Engagement of persons living with NCDs, and coming from the recent consultation that happened, which was led by WHO, how can this be translated into a civil society action plan? Our panelist is Dr. Pradeep Joshi, and he is the National Professional Officer, NCDs, the World Health Organization for India. Over to you, Dr. Joshi.
Good evening, everyone, and thank you, Ms. Ratna and Mr. Narendra, for giving me the opportunity. Hope I am audible. Basically, as the previous speakers have pointed out, we have to first think what is available at the global, regional, at the national level. There are so many documents which can be referred. First is this global coordination mechanism, which provides the report, and recently being held, which you have mentioned, on the civil society organization. We have a roadmap for 2030 to 2030 for implementing action plan. We have independent commission report, which is there. At the regional level, we have Colombo Declaration for strengthening health systems, and regional forum to accelerate NCDs prevention and control in context of SDGs. And at the national level, there is an important document which you may be all aware of. This is National Multi-Sector Action Plan for Prevention and Control of NCDs, which outlines the patient living with NCDs and what the civil society organization and government can do to address the needs. So these are the documents which are available, and most of these documents have addressed what is key required, which is human right approach, equitable access, affordability, community empower and engagement, and life course approach. So when we are drafting something, we also have to think over in that direction. And this WHO, as you mentioned, is organizing this formal and informal consultations, and will be actively doing this consultation in 2022, because the target is by end of 2022, there should be a global framework which the region can adopt and the countries can take guidance from that. So coming to the why patient living with NCDs and what is their primary role, and earlier speaker have also identified it very clearly, that we need to involve them in decision making, the co-designing and implementation of all the LCD policies, program schemes, which we have earlier heard from the speakers. And why it is very important, we have to understand, because when we are discussing, we have to understand that the patient living with NCDs have the first-hand experience of living with that, how they have experienced the interaction with the healthcare systems, and the other contextualization factors which help them to navigate to the different healthcare providers. So that first-hand experience is very important, and most of which we are talking about, and when we are developing this kind of any framework or other things, we have to include patient living with NCDs who are also healthcare providers, because they can help in both professional and personal experience in devising those strategies. So the important thing which I have earlier mentioned is that it should be based on the, it should include the marginalized population, minority population, and should be based on the cultural contextual factors, and should also address the dimension of inclusiveness, participatory approach, as well as looking into that what are the health and social support system which are there, and also what is the literacy and education level of the patients which we are talking about. There are some suggestions which I'm just reiterating those which we have discussed throughout this consultations, and this is something which we can think overall. First is we have to develop a consortium of the best practices or models. So that will help that evidence exist. So that is required first. Second is learning and leveraging from the other diseases, whether it is HIV, whether it's TB or malaria, how they have engaged. And we have to remember that all these diseases, especially HIV, has the patient living with NCDs, all this human right approach, their dignity, everything was duly taken care of. So we have to think on that one. The third thing which I want to reflect on is doing the stakeholder mapping and leveraging the strengths of what the other CSOs or members are doing and developing a network. The fourth, which is important, equally important, is the capacity building, because if we are trying to engage with the patient living with NCDs in the framework, they should raise their voice. So the capacity building of the patient living with NCDs through CSOs is very important. Fifth is providing multiple and convening platform where the patient can share their experience with the people, with the policymakers. And see, the patient living with NCDs have power to influence and inform the decision makers, and they have to power to modify the policies accordingly. So most importantly for this 5 is, without resources, it will not be possible, whether it is human resources or financial resources. And even the development partners or other sectors can contribute little bit, but the government need to come on board, and a proper mapping of how for the activities which we are defining, how the resource mobilization will be done will be very important. So that is something which the civil society organization or the Healthy India Alliance can start with developing a policy brief or toolkit, or creating a consortium of the best practices. So these are some of the reflections which I thought can be important in the discussion and taking forward the agenda of patient living with NCDs. And most importantly, when we are talking about the NCDs, we have to also think of that first of all, there are limited numbers of NGOs or CSOs who are working on the NCDs, and they are also into 1 or 2 areas. So how we can transfer that knowledge of what they have learned from the particular domain. Say, I would just take an example, whether from diabetes or cancer to the other NCDs. So that also is required, and the CSOs and Healthy India Alliance can play a very important role into that one. So I will stop here, and thank you so much for giving me an opportunity to reflect my thoughts. Thank you.
Thank you, Dr. Joshi. A person who has the disease has the best knowledge about the disease. What a powerful statement that is. And thank you for providing us with a very clear roadmap on how the Healthy India Alliance can move forward into actionable points. So without much ado, we will now move on to our next speaker, which is Dr. Akash Malik. And Dr. Malik is a Senior National Program Manager, United Nations Development Program, and he will throw some light on how community engagement with a focus on CSOs and persons living with NCDs can help us move forward. Over to you, Dr. Malik.
Thank you, Ratna, and thanking all the organizers, especially Dr. Monica and Dr. Radhika, for inviting me to this important discussion. So yes, and as we are already running behind time, so I'll just make a couple of points regarding the topic which has been assigned. So as Dr. Pradeep Joshi has already highlighted a very important point, that it's the people living with NCDs who will actually help us to develop strategies and interventions to reduce the burden of NCDs across the country. So I would like to highlight, how the UNDP next 5-year plan from 2023 to 2022 to 27 is, focusing on marginalized populations and also people living with various diseases, including NCDs. So the strategic priorities for the next 5 years for UNDP is to focus on 4 Ps, that is people, prosperity, planet, and participation and partnerships. And we have identified 3 enablers for this strategic priorities. That is strategic innovation, digitalization, and development financing. Though the speakers before me have already touched upon it, but I'd like to still, highlight the importance of each of these strategic priority and how it can be used to design a framework for involvement of people with non-communicable diseases in developing frameworks for prevention of NCDs and control of NCDs in India. So talking about the first strategic priority is people. And when we talk about people, we talk about, accessibility to universal, accountable and quality of healthcare. And vis-a-vis adoption of healthy lifestyle practices as well. And, as my esteemed speakers before me have already spoken about the various government, initiatives, starting from the Eat Right movement and the Fit India movement, which talks about adopting healthy lifestyles. Also, another important aspect is, ensuring that the people, the children, women, and the vulnerable populations have good and equitable access to right nutrition and food services. So that is also very important to prevent the younger generation from delaying the onset of NCDs in the younger population. Second is prosperity. When we talk about prosperity, we need to talk about how we bring the people living with NCDs into the value chain and help them to contribute to the demographic dividend of the country. This includes a wide variety of interventions, starting from stronger and more NCD favorable insurance practices to supporting accelerator labs and startups which have been started. We know a lot of startups have been started for NCD, starting from glucose monitoring to foot ulcer detections, etc., which many of those which have been started by people living with NCDs. So again, reiterating what Dr. Pradeep said, so it is the people living with NCDs who come up with these innovations and have come up with various startups. So we need to identify areas where we support these startups through accelerator labs and see how they can be scaled at large and benefit the other people who are suffering from similar NCDs. Third, as P is the planet, and we all know that air pollution is an important aspect which contributes to the burden of NCDs. So we at UNDP and I'm sure we had discussions earlier on how we study the aspect and identify interventions which reduce the burden of air pollution on NCDs. So we need to also bring into the aspect of green development and climate and environmental resilience, so that the burden of air pollution on NCD is reduced. And last but not the least, talking about participations and partnerships, various platforms, various innovations, and various interventions by the government and CSOs have been highlighted in the last 2 hours. And I think they can help in developing platforms which can, again, bring all these together on a more regular basis. Also, like the multi-stakeholder action plan, which was mentioned earlier. So even UNDP is, along with WHO, is taking the multi-stakeholder action plan as the overall framework around which we are supporting the Ministry of Health and Family Welfare for increased and better implementation of the NPCDCS program. So I will just keep it short because it is already too late and there are speakers waiting after me. So that's I like to end my session here. So thank you so much.
Thank you, Dr. Malik. Narinder, are you speaking?
Yeah. So thanks, Dr. Ratna. Thanks for the earlier speakers. Now I am just calling the third speaker in the line. I'm delighted to invite Ms. Smriti Rana, Head Strategic Program and Partnerships from PLWNCDs India, to suggest a roadmap for the meaningful engagement from her domain expertise. Dr. Smriti Rana.
Thank you, sir. And thank you, Shridhar and HIA, for giving palliative care prominence in this roundtable. I'd just like to share my screen as well, please. So my lived experience has been that I've been a caregiver for patients with cervical cancer in my family, as well as people with significant mental health issues. And I'm here to talk about the role that palliative care can play in the way forward. So the pervasive myth about palliative care is that it is end-of-life care for terminally ill cancer patients. And while palliative care does include this, it is certainly not restricted only to these aspects. But this in and of itself is a major barrier to accessing palliative care. So just one moment. So the aim of palliative care is to reduce all serious health-related suffering, and this may be applied across a vast spectrum of NCDs, as many of you here know, and at various points of the trajectory of the illness. And the focus is on quality of life for patients and their families, and continues into the bereavement process. It certainly comes into sharper focus as the person begins to actively die, but has a role right through the trajectory. Now, like most low and middle income countries, the need for palliative care in India is very high, simply because disease-specific treatments do not necessarily reach patients in time or early enough. So the WHO definition of palliative care includes life-limiting and life-threatening conditions. And so in this context, we also include conditions like paraplegia, spinal cord trauma, congenital heart disease, and so many other illnesses. In the West, there are parallel care systems that take care of people with such conditions and provide the entire gamut of support, but a significant percentage of our population doesn't have access to that. So that makes palliative care even more significant. We, especially in low and middle income countries, continue to defy a quick and comprehensive definition of palliative care. In the 67th World Health Assembly, the WHO did direct and encourage all member states to take a greater interest in palliative care for adults as well as children. Now, while this was a landmark resolution, it really took a global pandemic for us to really see how essential it is. And trained or not, during the pandemic, many healthcare workers found themselves struggling with aspects such as communicating difficult news, symptom control for breathlessness, end-of-life conversations, end-of-life care, and the grief and bereavement process. So at the time, as a response, members of the palliative care community, majority of them from Kerala, came together to create this e-resource toolkit. It follows a very simple algorithm format to enable physicians and nurses and healthcare workers to be able to manage COVID-19 through a palliative care approach. And what we really did was break it down into these 5 domains of shared decision-making, which included goals of care and ethical prognostication, symptom control of not just pain, but other things like agitation, delirium, breathlessness, communication, which was a very important aspect of addressing collusion, compliance issues, difficult conversations before and after the death, end-of-life care, of course, to make it more accessible, more appropriate, I would say, and certainly more affordable. And finally, emotional and spiritual support, which looks into compassionate care for the family, for the patient, as well as looking into the emotional support needs of healthcare providers who are currently going through such a hard time. While this came up as a response to COVID-19, I cannot overemphasize how relevant this is across domains even now. Some of you might be familiar with this, that the 2015 Quality of Death Index pegs India at an astonishing 67 out of 80 countries. And this study took into consideration 20 qualitative and quantitative indicators. And the thing that countries with high quality of death index had in common was also a firm acknowledgement of palliative care and access to essential medicines for pain relief. So what is missing? plenty, but a lot also can be done. In a resource constrained setting like ours, medical education is a very, very important touch point. And elements of palliative care were only brought into the medical curriculum as recently as 2019. And while that is a tremendous step forward, we are also facing a paucity of trainers who can actually go ahead and train medical students. So efforts are underway now to mobilize and to convene and to train these trainers. As mentioned and articulated so beautifully by Dr. Balasubramaniam, and under his guidance, the NHSRC has undertaken capacity building of frontline workers in various aspects, including palliative care, mental health, and elder care. And we need to support the NHSRC in enlivening this. And one important, it took decades of civil society advocacy to have that law amended in 2014 to make pain relief more accessible to our own country. And while the law was amended in 2014 and the rules changed in 2015, a vast majority of states in India have still not implemented these changes. And that is a major barrier. So that is something that as civil society, we still have a lot of work left to do. So while UHC recommends that health for all must be health with all, and that communities must be included in the designing and implementation of healthcare services, one example of this is the Kerala model of palliative care, where we have leveraged the power of community to really get access to people in places that they wouldn't have otherwise gotten access to. So community volunteers trained by us become our hands and eyes and feet and hands on the and eyes on the ground. And this is a model that has been celebrated, certainly, but I strongly believe, as do the rest of the palliative care community, that every state in India has its own ideal model waiting for it. And what has really underscored success has been this partnership between civil society actors, government, and professionals. So, there are several points. Suffering should be something that is addressed across the trajectory of illness. So I will stop with that, Ratna.
Thank you, Dr. Smriti. It was very wonderful and exciting to hear you. And I would with this call our next speaker, Dr. Sutapa Biswas, Executive Director from Cancer Foundation of India, to share her experiences suggesting creative engagement from our intervention models. Dr. Sutapa.
Thank you, Narendra. Thank you so much. I just want to make a few points because I think we are the ones who are rolling it down, people living with NCDs. There are a few experiences that I have had, which I want to share with all of you, is that all the NCDs are very, very different and they have different requirements. If you look at cancer per se, there's so many types of cancers, which all, like stomach cancer has to be dealt differently, cervical cancer has to be dealt differently, then you have breast. So in cancer itself, you have so many types. Then NCDs, you have so many. So when we bring people living with NCDs on the same table, it becomes extremely challenging for them to understand or go beyond my story. Like I personally am a person living with type 2 diabetes. I have been a caregiver for cancer. That's why I am in Cancer Foundation of India. And I work for cancer prevention. So if I'm sitting in front of a policymaker, what do I take up? Which issue do I take up? Do I take up the one that I am living with or something which is important? So what becomes very difficult for us or any of the advocates whom we are so-called training, whom we are empowering, what do they do? So I think it's very important that all of us who are as advocates, bringing together other people living with NCDs, make them understand that we have to think collectively. It is not just my problem. What is the issue to be raised? So are we working for policy change? Are we working for community mobilization? What are we working for? So accordingly, we need to plan. I've been working for 20 years and I am in this sector of cancer prevention, which was completely new to me because I come from a different background altogether. And I was told in the beginning, you are not meant for this. You will fail. So I have heard all this for the past 20 years, and I know that I'm going to spend my lifetime doing this. I'm not going anywhere. So it is not a very easy journey for me, a person living with NCD or a person working for an NCD, because there's this word called living. Everyone thinks, oh, they're living with it. So that's what happened during COVID. Everything moved towards COVID because people were dying. And in NCD, since people are living, they're struggling, they're finding their way to live. So nobody was looking into it. So when we're looking for resources or funds, every company, corporate said, oh no, we've given it for COVID this year. Second year, they said, oh, it's all for COVID. NCD, what is NCD? Now we're not talking about it. So it's as if NCD was not happening. So there's a reality that's happening, at the ground below, which I think all of us should be mindful of. And having said that, what HIA can do, I personally feel, is that create the talking points. Yes, you're training champions, you're empowering them, great, but create talking points, create fact sheets which are simple with local data. Local data is very, very important. That we give them local data. There are so many languages, it should be able to be translated. It should have that element in it, simple enough to be translated into languages in the country. People should be able to understand. And somewhere, if it's possible for HIA to create a plan like we did for tobacco, that will work on tobacco laws. So every NGO in the country was focusing on the tobacco control laws, and which I think was great. Whatever impact we could was because all of us had a focus. It's a varied country. So somewhere I feel that, HIA could be doing that. The fact sheets, creating platforms, as Akash said, and others also, that Mr. Joshi, all of us have to have that platforms, yes, but it has to be visible. Platforms that are visible, because it is being created as a force. So if that force has to be sustained, it would take time for it to grow. So we all have to allow that space, bring them up, allow them to make mistakes, the groups to make mistakes, but still stay on there and speak their voice. All and each and every NCD, all are important. None of it are less important. Just because we are having more deaths does not mean that that's more important. All are important. So somewhere I think HIA has the capacity to do that, and I would really like that HIA takes it up forward in the coming years and becomes a force to reckon with in the country. Thank you so much.
Thank you, Dr. Sutapa. That was always a pleasure hearing you. Thanks to all distinguished speakers in our group and my co-chair, Dr. Ratna. Their shared experience and vision sure has set up a possible action agenda suggesting meaningful engagement of patient groups. It is very clear that more interventions are needed towards risk reduction to keep it cost effective and NCDs at bay. As a setup like Jan Arogya Samiti is a clear proof of ensuring wellness, which is part of risk reduction in a low resource setting arena. Otherwise, we need to be prepared for an expensive care pathway to manage the impact of NCDs. Like the Rogi Kalyan Samiti are the one which needs to be more capacitated, and they should be made to articulate their healthcare needs of clearly to make available needed services, mapping stakeholders, creating a consortium of patient groups to consolidate best practices were good examples for ensuring multi-sectoral approach and meaningful engagement, and drawing a policy brief from their experiences was also a very good suggestion. I think the expansion of primary health care horizon is a heartening aspect, and as rightly pointed out, we need to utilize these services optimally, creating a demand. Technological innovations like telemedicine, etc., can be added advantage to get expert treatment facilities immediately, and also reducing patient drudgery, ensuring larger outreach and much needed treatment during restrictions due to pandemic induced uncertainties. I ideally wanted mental health was also touched upon adequately. The district mental health program has to be put to good use, and the primary healthcare services should include this for easier access. Awareness is an important aspect to check stigmatization, which was also discussed in the primary part of this talk. So I conclude here. It was indeed a pleasure hearing all of you, and I thank you for your meaningful contribution. Over to the organizers. Thank you.
Thank you so much. So we will open it up for a few minutes if anyone would like to take away or highlight anything that's come to mind from this session, and after that, we will close with our vote of thanks. So if anyone would like to say something, please do.
I just wanted to say it was a real rich experience listening to all the learned speakers and having so many aspects of NCD covered, especially the last session with the passion on two very sensitive subjects of palliative care and cancer by Sutapa and Smriti. Of all the speakers were excellent, but these two were really very passionate and touching. And I think we really learned a lot from the rich experience, and I hope we continue working like this in the HIA as a collaboration. Very happy and proud to be part of this collaboration. And yes, Seema Bali also was an excellent champion.
Thank you so much, ma'am. Would anyone else like to add anything?
Hello, shall I add?
Yes, sir.
Yeah, it was excellent session. We learned a lot also. But what I am interested is we should concentrate on these NCD clinics, which are started at primary health care centers all over India, wherein all health workers and A&M sisters are involved. And along with that, where we give free diagnosis, free facilities for further investigations and drugs. Drug treatment is also free. There are cardiac care units, cancer care units at this level. Only thing we want to strengthen such activities. We can take, of course, help of the Jana Arogya Samiti at village level. What is important, government has come out with a very nice scheme. Only thing is proper implementation should be there. And for that implementation, whether we can help the government or the primary health care center, health workers and ANMs through any of our programs, through these renowned all these organizations, that is including WHO and all other, of course, nationwide organizations. I just wanted to know.
Thank you, sir. Dr. Ratna?
Thank you. I just wanted to say that I think when we started the consultation, we were navigating through each of the speakers' points. We really didn't know where we were going, but towards the end, we have achieved the purpose of this whole consultation of how we want to go forward, using the agenda of non-communicable diseases included into universal healthcare so that no one is left behind, and that we include the meaningful involvement of people living with the disease so that it is truly an engagement strategy and not just tokenistic. So all the panel speakers, all the presentations that happened today brought in nuggets of information. And it was very beautifully rounded up by the last panel, where we not only got a very clear pathway on how multi-stakeholder engagement can happen, but also insights into what meaningful engagement would mean to that multi-stakeholder engagement. So I think we did achieve the objectives of today's consultation, and I'd like to thank Healthy India Alliance and all our members for doing such a wonderful job today. Thank you.
Thank you so much, ma'am. I think given paucity of time, now we can move on to our vote of thanks, which is being given by Dr. Barsa Raut, who is with us at Hriday. Barsa, over to you.
Yes. On behalf of the Healthy India Alliance, I am happy to deliver the vote of thanks for this 5th National Civil Society Consultation on Non-Communicable Diseases and Universal Health Coverage. HIA is grateful to all the distinguished experts, people living with NCDs and civil society partners who shared their valuable insights on how to realize the vision and the mission of meaningful involvement. Today's deliberations have reaffirmed our resolve and commitment to prioritize people-led action for NCD prevention and control in our country. A special thanks to the co-chairs and the moderators for their efficient facilitation of the various sessions. Congratulations and thanks to Jan Seva Foundation and the Strategic Institute for Public Health, Education and Research for their excellent work on COVID-19 and NCDs in Maharashtra and Punjab respectively that was highlighted during the consultation. We are particularly grateful to the National Health System Resource Center, the World Health Organization, and the United Nations Development Programme for supporting our efforts on meaningful involvement. HIA is fortunate to have the support of NCD Alliance over the last several years for all its endeavors focusing on NCD prevention and control, including ongoing efforts related to meaningful involvement. We thank the NCD Alliance for enabling this organization for this consultation. We express our gratitude to all the members of Healthy India Alliance for their commitment and enthusiasm to take forward the agenda of the Alliance. Thank you to all the participants for adding richness to the deliberations with your active engagement. Please do get in touch if you'd like to know more about HIA and how to get involved at. You can reach out to us at HIA secretariat@hridayshan.org. In conclusion, I thank all my team members at Hriday for this constant support in organizing this consultation. Now we will meet you next at the 6th National Civil Society Consultation on NCDs. Thank you and good evening.
Thank you, Barsa. Thank you to all our resource people and our participants for enriching these discussions.
Thank you. Thank you, everyone.
Thank you, Ajay. Yeah. Thanks, Radhika.
Thank you. Thank you, everyone.
Thank you. Thank you, everyone. Really appreciate your time.